Good afternoon. It's my great pleasure to welcome you all to today's program, Understanding Long COVID, the Unseen Public Health Crisis. I'm Michelle Williams, Dean of the Faculty here at the Harvard T.H. Chan School of Public Health. Back in August, Dr. Stephen Phillips and I wrote a piece for the New England Journal of Medicine entitled Confronting Our Next National Health Crisis, Long Haul COVID. Why did we sound the alarm then? We wrote the piece because long COVID affects millions around the globe, yet we barely understand this emerging condition. We barely understand its devastating and long-lasting symptoms that prevent people from working, that prevent them from socializing, that prevents them from parenting, and in fact prevents them from carrying on with any sense of normalcy. And like so many chronic disease sufferers before them, COVID long haulers face ambivalence and even outright distrust from the very health systems responsible for taking care of them. Today, you will hear those stories firsthand. Our goal for today's program is not only to better understand this condition, but to put patients at the center of this conversation in order to head off the next public health crisis. With that, I would like to turn over the podium to Fiona Lowenstein, a journalist and founder of Body Politic. She is also a long COVID sufferer herself. Welcome, Fiona, and over to you.
Thank you so much, Dean Williams. It is truly an honor to be here today and to have this opportunity to speak about this incredibly important topic. I myself have experienced long COVID as a patient, and I can tell you firsthand that this is a disease that can be at times both incredibly devastating and can also feel very confusing to experience. For those of you watching today, we would love to hear from you and take your questions. You can submit those questions via Facebook at facebook.com/Harvard Public Health. I'm so grateful to be here and have this opportunity to moderate what is both an incredibly important and timely discussion. And I want to welcome everyone in the audience who is watching today. With that, we're going to begin by hearing some firsthand accounts of long COVID from the patients who are experiencing this disease to better understand both the scope and the seriousness of today's topic. Let's take a look.
As a 31-year-old woman, I wasn't able to take care of myself, wasn't able to function.
I wasn't able to move my body. My limbs felt like lead.
My jaw was tight, I could barely chew, I could barely swallow more than one bite. And my heart was racing again, I felt dizzy, lightheaded.
I was in pain with neuropathic burning pain in my feet and my hands, aching pain in my back and my neck, and a headache.
Now I spend 85 to 90% of my time confined to my bed.
I noticed that there was blood in my vomit. And at that time, I felt both terrified and ashamed.
You know, I was a first-time mom, and I had a 2-year-old son. I wanted to play with him. I wanted to be able to pick him up, but I couldn't even stand up.
I have been unable to work since April 2020. I was terminated from my job.
I also have battled suicidality as a result of long COVID, being disbelieved, having my pains attributed to a psychological source when they stem from a physical source first and foremost.
They threatened to have me arrested for asking to be tested and seen while my oxygen was dropping.
We have the right to dignified lives with rest, with care, with support.
We are in dire need of help and research.
Wow, that's a lot to tackle. It's very moving to me just having experienced so much of this myself. And I think what strikes me most is the intense isolation that these folks are facing. That feeling of just having no one to turn to is so relatable and so scary. But before we all react, I want to take a moment to introduce our panel. We have an amazing group with us today. Joining us is Dr. Wes Ely, co-director of the Critical Illness, Brain Dysfunction, and Survivorship Center at Vanderbilt University. Dr. Gary Gibbons, the director of the National Heart, Lung, and Blood Institute. Dr. Kavita Patel, a non-resident fellow at the Brookings Institution, Dr. Stephen Phillips, Vice President for Science and Strategy at the COVID Collaborative. And we're also joined today by two long COVID patients and advocates. Hannah Davis is the co-founder of the Patient-Led Research Collaborative and is a long COVID patient herself. And Shamir Smith is a long COVID patient who is advocating for others in her community. So let's dive right in by just talking about this tape we just saw. I can certainly relate to the pain and the suffering that these people are experiencing. And as I said, I think what strikes me the most is just this sheer lack of acknowledgement that so many long COVID patients have dealt with. You know, I myself witnessed this as a patient. So Dr. Patel, I want to turn to you first. Why and how do you think this happened? And why do you think so many people with long COVID really feel that they've been ignored?
Yeah, thanks for having me, Fiona. I want to say this is like a bucket list of mine because I've been learning from a lot of my co-panelists and having to apply some of these things in real life. So my primary identity that I come here today, because I wear a lot of hats in my life, is really as a primary care physician in a federally qualified health center that at one point in time had about a two-thirds positivity rate of COVID, mostly brown and Black communities in the very, very, very kind of socioeconomically devastated part of Maryland. Shamir, I think, is kind of close to where I am clinically, but what I saw unfolding as people were coming either out of ICUs, out of hospitals, or never needed to go to the hospital, but were coming back into clinics when we were in person, were just a lot of voices that were scared to actually even talk about symptoms that might be even perceived as long COVID because of what we just heard kind of passionately. And I think, Fiona, you've spoken about this before, that outright they get dismissed. And if any of you have read Malcolm Gladwell's book, Blink, you'll understand why that fear is like very valid and in a really smart basis. So it was interesting to me because I had been kind of primed learning and listening to people like Wes and others on this panel that I had to look for it. And people were scared to tell me, young women, mothers who were scared to give it a voice because it would be immediately dismissed, been told that they were crazy. There were cultural norms that went with it, that they were broken or weren't X, Y, and Z enough. And I think that has, honestly, in kind of doing work in primary care, it reminds me of a lot of the stigma I see with depression and with mental health. And the things kind of converge in a way that have actually hindered clinical curiosity. So if you can't really feel that in a 15-minute visit that you can try to understand what's happening, the instinct, even from the best of doctors, myself included at times, is to just move on to the things you know you can do. And that's not dealing with long COVID, or before we even called it long COVID, we were trying to understand, like, is this a reinfection? What does this mean? And we were looking for blood tests to kind of validate things. And when we couldn't find like the kind of tidy results that we like in clinical medicine, it made a lot of us frustrated, and it still does. And I'm still frustrated to this day because I have people where my only answer is, I really don't know. And I have no idea how to help you. And I will try to find out. That's incredibly unsatisfying for clinicians who are trained in Western medicine to have answers and differential diagnoses. And it's even more frustrating, I think, for the families of my patients, which I think maybe we'll be able to talk about, Fiona. I see this look of sadness and desperation, not necessarily just in like the eyes of the person in front of me, but if you look around them, it has this ripple effect that's like pretty devastating and hard for me to even acknowledge.
Yeah, I think those fears are so widespread, and I'm glad you brought up the families as well. I think we'll definitely get to that. Dr. Eli, I want to go to you next because I know you're also on the front lines of this as a critical care physician. And I think when people think about that kind of, hospital setting, they're thinking of acute cases of COVID, but we know long COVID patients also sometimes require hospitalization. Are you seeing those similar fears in the patients you're treating? And what has been your experience treating long COVID in your daily ICU care?
Sure, yes, and thanks for having me. And I really appreciate all the things that Dr. Patel said. I completely think she's on point there. One of the things that grabbed me in that video of all those patients that just grabbed my heart was that you could tell that they were speaking from a place of sincerity and honesty about their own lives. And they are, let's make sure we're clear about this, they are the experts of their own illness. And what they were being told was that they weren't the expert of their own illness. This is a disease that's a pathophysiological consequence of infection by SARS-CoV-2. This is not a psychosomatic illness. And when people are made to believe that they are dreaming this up as if it's psychosomatic, that is really, and let's call this what it is, it's a form of testimonial injustice. People are being silenced, and everybody in society right now is about let's fight against injustice. Well, this is a public health crisis, and there's a driving unmet need for us to acknowledge that the patient is the expert in her, his, their disease. And we need to quell this notion that it's okay to say that it's in their mind. The other thing I wanted to say about this, you brought up the intensive care unit. You know, I'm an ICU doctor and I work at Vanderbilt University, and I run a research program called the SIB Center. It stands for Critical Illness, Brain Dysfunction, and Survivorship. So the S, that anchoring letter in SIBS, is all about survivorship. And this disease that I take care of in the ICU, when I take care of somebody on life support, when they get out, my job is not over. If I think my job's over, I'm failing at my job, because every human being is of infinitesimal value and worth. And no amount of disease reduces their dignity or reduces their value. And when they leave the hospital, going to suffer from either PICS, which is post-intensive care syndrome, which is the acquisition of a dementia, you know, cognitive impairment, depression, PTSD, and muscle and nerve disease. And then 100 days later-ish, develop this entire spectrum of the pathophysiological consequences of long COVID. If I am not willing to follow that person into their survivorship, then I need to re-question my vocation as a physician. And I think there's a lot of structural things we need to address. I'm going to quit talking so I don't give too long of an answer. But later on, I hope we can come back to what the primary care doctors are finding so difficult in saying, I don't know, and how their life really is very difficult to see now millions of new people that wouldn't have required care before, but now all of a sudden are inserted into our system when the system is not built to accommodate for them. So let's get back to that later. But those are my thoughts, Fiona, off the top of my head.
And Fiona, I'd like to, you know, to kind of speak to what Wes and what Kavita were saying. I especially understand about coming to an awakening last year, probably around May or June, when I realized that what was happening to me at the constant, you know, going to the hospital, I was going to Johns Hopkins. It seemed like every other day I was going, and I was left in rooms for hours and hours. And then I would have doctors, usually, you know, white male doctors, who would look at me and say, oh, well, there's nothing wrong. Everything is fine. Go home. And if something was wrong, then you just take the 2 weeks and you'll be fine. And I oftentimes think my 2 weeks has never come, right? And so speaking of injustices, I remember feeling at the end of June, before I spoke out, I said to myself, I said, for some reason, everything I'm experiencing feels like racism and sexism in healthcare. And it felt like an immediate injustice. I couldn't quite put my finger on it. But then as I started to think about it, I said, I have to speak out about this. At that time, you know, George Floyd had just been killed. And I said, you know, I wish I could be out there, you know, protesting with other people. I said, but what I did remember was, if I can't be out there because I was so sick, what I could do was start to speak for my community of people who perhaps had long COVID, who may not have known what they were experiencing. And I also thought about my low-income families of the students I taught. And I said, I can't imagine that what is happening to me, the dismissal, me being accused of needing a further psychiatric treatment, me being accused of being a recreational drug user because I was explaining bizarre symptoms and cognitive impairment and eventually a loss of vision. I could not imagine that continuously happening to my students and their families, and they often live in the same households. So I had to speak out. And so I did, you know, I have tried to address those injustices. And Wes is right, it is an injustice. It's not fair. And plenty of people are still suffering up to 20 to 24 months later, because at the very beginning of COVID and now long COVID, we weren't doing our work. We weren't paying attention. We were so quick to make people wrong or to send them on their way or to pass the buck, that we didn't address what needed to be addressed. I believe had we addressed it from the beginning a little bit better, than a lot of the millions and millions of patients who have long COVID now possibly could have been avoided.
I agree completely, Shamir. And I think a lot of us who got sick in that first wave had that experience of kind of being the canary in the coal mine or the guinea pig, right? And we know medical racism is real. We know medical sexism is real. We're hearing about that. We're hearing about disbelief, of patients, and we're hearing that these healthcare systems really aren't equipped to deal with this crisis. So, Dr. Gibbons, I want to ask you, you're the director of the National Heart, Lung, and Blood Institute. What do you see as the nation's next step in treating long COVID and dealing with this crisis?
Well, thank you for that. So first, it begins as you began, with the patients suffering this devastating disorder. And as we always do as clinicians, come alongside them. Wes said it well. It tugs at your heart. And indeed, one of the early things that the NIH did in responding to this recognition of this syndrome was to first heighten awareness that this is real, that it is not a psychosomatic illness, as Wes indicated, that this is related to the SARS-CoV-2 virus infection and its effect on the body, just like it affects the lungs and creates the blood clots and creates the pneumonias. This is one of the consequences of that infection. In fact, we presented that to members of Congress last fall, alerting them to what was emerging. This pandemic, this virus is teaching us something every 2 months, it seems like, in its twists and turns. And we recognize this relatively early, to the point where Congress fairly rapidly created an appropriation to study long COVID and appropriated that in December, January of last year. If you think about it, that actually was relatively fast, quite frankly, for Congress to do anything, to recognize a problem and then appropriate funds within a relatively short period of time. And that's put us in a position this year of putting together a program as rapidly as we can to try to understand it, to figure out the risk factors for long COVID, and eventually what's driving it, to understand that pathophysiology that Wes was talking about, that we always want to understand in order to target an effective intervention to prevent and treat it and end the suffering. And that's what enabled us to launch Recover, Researching COVID to Enhance Recovery. That's this initiative in which we started, as you started, Fiona, with listening to patients. And quite frankly, I appreciate there's some on the panel who in fact were participants in those listening sessions. And quite frankly, again, it tugged at my heart for sure to hear the stories, the testimonials, the lived experience of patients suffering from long COVID. And that was critical to formulating the initiative. In fact, those listening sessions were a direct part of really our sort of coalescing principle around doing this research in partnership with patients suffering from long COVID, and indeed invited patients to be at the center of this effort and participate. And quite frankly, again, there are a few of you actually on this panel that joined us as we're formulating this initiative at the table alongside researchers and the traditional groups that do these things as partners at every level. We look forward to maintaining that sort of patient-centered focus. I'll stop there.
Dr. Gibbons, can I ask though? So I trained as a health services researcher. I have a deep respect for kind of the research trajectory. I think many of us are frustrated, and I'm asking, how will you kind of make sure that Recover, which is incredibly important, kind of how do you balance being able to also relay information or insights kind of in a real learning environment? Because I'll be honest, I get more insights on Twitter with what to do than I have, frankly, from sending people to like tertiary or quaternary, to large centers where they have COVID clinics, because those clinics are full. I have, it's hard for me to tell people you may not get in for 6 months. So is there some appreciation for how to balance that, which is generally not something that you can see with kind of, large research efforts? Kind of expediency is not necessarily the objective.
Well, so I think if I understand your point, Kavita, that this is a challenge in the real time of the pandemic, where we're trying to understand a new disease, raise awareness about it, understand it to the point where we could hopefully prevent and intervene and treat it all at the same time, and ensuring that providers have the information they need to address this with their patients, all in real time, in the middle of a pandemic. And so, yes, this is a challenge, but that's really one of the reasons I'm delighted you put together these panels, is that this is going to be a collective effort. That's why we were engaging all the stakeholders in the whole ecosystem in order to address this. So we need patient advocacy groups like this. We need to leverage the social media platforms that you all are engaged in to be amplifying voices and authentic voices, because again, this is your lived experience. As Wes said, and I totally agree, patients are the experts of the disease and how it's affecting them. And so that's why we want to join with your voices in a collaborative effort as partners. That's the only way I think this can be effectively done in the kind of rapid way that you're describing. And that's why we want patients to be at the table as we design the research, as we execute it, as partners in participating in it, as well as you're indicating, disseminating what we know, and hopefully being a part of the front line of implementing the kind of interventions that we hope will reduce the suffering.
I think we have a thought from Stephen. Do you want to chime in?
Yeah, so just listening to this great panel, it just strikes me that we're all on the same wavelength of mutual support, meaning that we have some primary care clinicians, we have ICU specialists, we have long COVID patients, activists, and we all represent, I think, a very symbiotic community here. We're in violent agreement that patients need to be listened to, they need to be trusted, they need to have a responsive medical care system where physicians listen, work them up in ways that are consistent with their symptoms. And I keep wanting to turn us toward the solution as well as a graphic statement of the problem, which I think we've stated quite eloquently. And I think the solution is partially to recognize that we're operating in two paradigms. There's a biomedical paradigm that about half of the panelists are a part of. We've been through conventional medical training and are medical practitioners, and others are patients. And the patients are in the patient-centric paradigm. The reality is that we have about 500,000 medical practitioners in the country that are aligned pretty much in modes of practice and healthcare that are biomedically centered in terms of culture, philosophy, and practice. And then we've got long COVID patients that represent a pandemic within a pandemic. It's incredible what the numbers are. Probably millions to tens of millions of patients will have long COVID symptoms. And at this point, self-diagnosed and self-identified, which by the way is not a problem. It's probably the first self-identified illness in the history of humankind. The question is, how will these two paradigms that have been acculturated to think and act and perform differently reconcile their differences? And there are some, I think, powerful examples of things we can all be doing on both sides to come together.
Hannah actually embodies one of the solutions here that is kind of exactly what you're talking about. I actually, Hannah, let's go to you. I want to hear a little bit more about, you co-founded the Patient-Led Research Collaborative, which really puts patients in the driver's seat as researchers. Can you tell us why that was needed and why you created that initiative?
Yes, absolutely. I think in part because of this kind of, I think it's a false dichotomy to kind of put patients and practitioners against each other, especially right now, as we found 20% of people with long COVID are healthcare practitioners. Were in the medical field. Of course, they were, the ones directly involved with patients. And we have doctors in our group who are now both doctors researching long COVID and patients with long COVID. So I think that's kind of kind of a direction we want to see happening more. Is this is not one versus the other. I do want to address this self-diagnosed issue. There's kind of a collective amnesia about what happened in the first wave. We know now that 1 to 3% of cases in March 2020 were recorded. That means 97 to 99% of people who got COVID in March 2020 did not get a recorded test. So what are you going to do? You have to self-diagnose. We also know now that 1/3 of people don't make antibodies and that 2/3 of people with mild cases seroconvert by 60 days. So that is literal millions of people who got sick with COVID who don't have that proof of COVID. The solution is not to kind of put them in this class of self-diagnosed. This is to recognize the kind of historical events that were happening at the time, which is that testing was not available outside of hospitals until May, basically. That's so many millions of people. And I think that's one of the things we as patients constantly kind of have to keep advocating for, and we include in our research. I think for the Patient-Led Research Collaborative, one of our goals very early on, I mean, our whole reason for existing really was that we had no answers. A lot of us in particular were not having kind of the respiratory COVID, we were having the neurological COVID, including myself, including Shamir, that no one was talking about back then. And so our first goal was really to kind of get an understanding of these symptoms. When we joined Body Politic and we saw literal thousands of people saying, like, I cannot remember my son's name. Like, I just almost got hit by a car because I didn't look both ways to cross the street. We knew that this was a phenomenon that was just happening around the world, and we kind of wanted to get it out there. Basically, what we want to do is answer the questions that patients have just nonstop, thoughts about that impact their lives. Like, early on when we started talking about this cognitive dysfunction, we would hear, oh, this is only in older patients. So one thing Patient-Led Research did is we analyzed that. We said, what kind of cognitive dysfunction are you having? What kind of memory loss are you having? And we found that those symptoms were as common in the 18 to 29-year-old group as in the 60+ group. This is widespread. This is not discriminating by age. So that was an answer we could give patients. Another one was, because we had this huge cohort without positive PCR tests and without antibodies, we actually looked at the cohort who tested negative versus the cohort who tested positive. And what we found was that the difference in those cohorts was not in the symptoms or in the symptom trajectories over 7 months, but in the amount of time it took them to get tested. So the positive cohort got tested at an average of 6 days. The negative cohort got tested at an average of 43 days. So you've got like an answer there. And then patients can take that to their provider and, this is now a peer-reviewed published paper, and say, oh, this is like the cohort I'm in. My symptoms are the same. I didn't get a PCR test because I wasn't wealthy, I wasn't connected, or I wasn't hospitalized. So I think
that issue of testing and how to actually diagnose this disease when these tests are, sometimes hard to access, sometimes unreliable. I mean, a new T-cell based test was able to find evidence of COVID in 42.5% of people with long COVID that had no antibodies. So thinking about this, I want to pivot a little bit and ask you, Dr. Patel, about a recent controversial study that came out that actually used these tests, despite some of the issues, to try and prove that a majority of long COVID patients may not have ever had COVID, implying that, symptoms might have been psychological. Now, to me, this seems something that could do real harm to patients with a real disease. And I know, Wes, you've been talking about this on Twitter as well, so I want to go to you next. But Dr. Patel, can you tell us a little bit about your thoughts on that study and just kind of how to diagnose this illness in general?
Yeah, I'll just say briefly that anyone who thinks that they've got like a black and white clarity about the demarcations for this is honestly just being deceitful, because kind of to the point that this is a novel virus and so much of it, I still think there's just so much we don't understand. And my concern about not just that study, but then it kind of has spurred into like this viral phenomenon, again, to your point, of making people feel less inclined to ever come forward or to not advocate for themselves, because it just takes that many more efforts to try to find someone. And by the way, it doesn't have to be a physician, but just to find anybody. It can be a dentist, it can be someone outside of the healthcare profession, but someone who understands. So my kind of bigger concern, unfortunately, I can't help but kind of leap to like the policy implications, and I'll let Wes and others talk about like some of the studies in detail. My concern is that that's going to start to then become used to think about denying coverage or to make and create barriers to even more comprehensive care, because like as we get past like the kind of public health emergency time period, it is very clear to me that we're going to have a number of people where when I didn't even have like an ICD-10 code for the longest time to kind of document. So I was documenting things like fatigue, stomach pain, back pain, joint pain. And we're going to have so many people where that's all I can do is kind of target symptoms and never actually fully acknowledge that these things are related. And also to your point, like we do a lot of damage by associating one diagnostic criterion, so to speak, for something that we fully don't understand. And we've seen this probably, my co-physicians on the panel and also patients can relate to this. This has been a problem with other inflammatory kind of diseases. So I get very nervous when I see studies like that then somehow become like, de facto the science by which we use. And it tends to be used, I'm going to say something, I try not to be this super inflammatory, but I see this. It tends to be then used for the very same people that really don't want to deal with this and want to try to kind of just, just push it aside because it's not something that's easy to deal with. It becomes the like unfortunate way to say, well, they didn't meet this specific and they don't have these T-cell responses, therefore it can't be this, refer to behavioral health. And I see that referral a lot. And then it also minimizes and marginalizes that there's actually an important role in behavioral health, but it's as part of like a collaborative effort, not as a default because this person is crazy.
Let me say this, Fiona, before you get to Wes, as a patient. I know that it's so easy, as Hannah mentioned about, it's so easy to place a versus, patients versus doctors. But I'll say this, last year, I had so much trust in doctors, right? I thought my Care First card was my golden ticket to be able to get great care. As you all know, that didn't happen for me. Everything I found out about COVID and long COVID and everything I started to share with other people about my experience happened from support groups. The very first intricate survey that I did was with PLRC. It was one of the first surveys that really delved into exactly what my neurological symptoms were, because that's what I suffer from the most. I think that what needs to happen is in any injustice, there has to be an upset. There can't be a reconciliation of injustice until there's some type of upset. And like Stephen said, as patients, what we see is this is the largest movement of patient engagement, patients who care, patients who are creating their own research studies and their own research groups and their own support groups. But I think what has to happen is, and I'm still suffering from it now because I recently was just diagnosed with severe depression from long COVID, right, as a part of my symptoms, as well as PTSD. And because of all of the dismissal, all of the racism, all the sexism I experienced, with a doctor telling me in July of last year that COVID did not impose or cause any neurological symptoms. He wanted to tell me how many schools he went to, but he would not listen to me about the fact that I suspected that I had occipital neuralgia until the very end of my stay. He was like, oh, I think you have it, right? So I think what needs to happen, and it's going to take time for patients to lose sort of like a resentment towards the medical community. I hate to say that, but I think unless we get real about that, it's going to be difficult to kind of try to find some balance. Because for me, I'm very afraid now. I've been scheduled for 7 appointments between now, the end of the year in 2022. And I'm going to tell you, I am deathly afraid to go back to a lot of those doctors, because my fear is still almost 2 years later that I still run into doctors who have no idea what I'm talking about, and they refuse to listen. All these medical records I have, all of this, all the things that I've been a part of, and they still don't listen. So I think that for some patients, honestly, and with good reason, we have developed post-traumatic stress from dealing with doctors, right? For good, bad, or indifferent. And I think that's something that we really have to talk about, and we have to really try to move through, not move past, but move through. I'm in therapy right now to deal with, how do I approach doctors going forward? What are my future interactions with doctors so that I can get the best care possible? Because honestly, I'm afraid.
Yeah, I want to say, Shamir, that I want to apologize on the behalf of the medical community for what we have done to you, and we have injured you. And I carry a moral injury because I know I've hurt people along the way, in the way that I cared for them in the ICU, and in the way that I cared for them in survivorship. During COVID, I actually had to process my own shame and grief and the weight of this. I wrote a book. It's called Every Deep Drawn Breath, and it's just raising money for COVID survivors, because I feel like I've got to do something to come back from this. But, I watched you nod, Shamir, during the video when one of the persons talked about suicidality. And I'm not saying that you did that, but I saw you nod. And when I had a piece in Stat News a few weeks ago called Silencing Long COVID Patients. And there was a beautiful Atlantic story that I linked to in there about the physical pain and suffering caused by being silenced. It creates an injury that all of you were telling me about. And I hear you, and we all need to listen better to you. And so first, I wanted to apologize to you. I'm thinking right now of one of my patients who has COVID, and she's gone deaf. She lost her hands and feet too. So she's had a lot of surgery, a lot of problems from COVID. Another one of my patients is blind from COVID. Those are easy things to see, but unfortunately, many people suffering from long COVID have on the exterior what looks like to everybody else is normal. If you look at Hannah or Fiona, people look at them and they think, oh, they look normal. They're not sick. Or you, Shamir. And what happens is that doctors in Western medicine, like Kavita said earlier, were taught to look for structural things that they can pin their hat on. They're taught to test for a diagnosis. And if the antibody test comes back negative, they don't have that problem. Well, long COVID, the pathophysiological response is not following that rule set. Period. End of story. You cannot diagnose this with antibiotics. There are way too many people who don't have the antibodies. Beautiful study in Lancet Respiratory just showed that 40% of elderly patients months after they have documented COVID have no detectable antibodies. So this is out. Okay. This is a clinical diagnosis, and we have to believe you. One of my patients said to me, I wish my hand was cut off, because then people would see that something was wrong with me. His name is Alden Huslett. He allows me to use his name. So in solution, I want to provide some solutions here. Some of the solutions that I'm thinking of are as follows. I'll give you three. One of them is Hannah Davis and Fiona. This is Hannah's paper that she published in eClinical Medicine. It's a beautiful paper. Hannah, you did such a great job first authoring this paper with real data to help wake up doctors like me that this is a patient-led, literally your group is called patient-led research program. And it's such a beautiful example of the bridging between people and academics like myself. I mean, I'm at the bedside, so I'm a real doctor. I play one on TV anyway. But also people in academics, where this ivory tower stuff is being bridged by people like Hannah, who are giving us real numbers and real data from these groups. Second solution, and we got to keep that going and growing. Second solution is, this is not a technology-driven disease in my mind, because the doctors fail Shamir if we go in there and say, okay, Shamir, you're here. I'm going to test this, this, and this. 5 minutes of time with you. That's enough. No, that is not enough. I need to say, not what's the matter with you, Shamir, but I need to switch the preposition to to and say, what matters to you, Shamir? And then I need to shut up and listen to you. Tell me what matters to you. And that is about switching technology first, putting technology second First is touch. I need to have touch first, technology second. And that's a way to rebuild this community that has injured you, Shamir, is to restructure our way. Every doctor can do that. We can walk in the room and say, what matters to you? Let me listen. We do need to restructure it. I'd love to know what Kavita and Gary, others think, that we need to give people longer time slots to see these long COVID patients, because these 15-minute time slots don't work. And the last thing I want to say, and I'll shut up, is we can teach people compassion. Compassion is not something that is innately born inside of every human being, but it is an instrument of healing that can be taught. In 40 seconds, this is scientifically shown, in 40 seconds can establish something that builds trust between you and me by saying, Shamir, I don't know what you're going through. I know you're suffering and I don't understand it, but I will not leave you. And I don't know what I want to know to take care of your long COVID, but I will form a promise to you, a covenant that I will stay with you in this. And when I don't know, I'll tell you I don't know, and I won't disbelieve you. And that's how we can start to move forward with this long COVID community.
I want to add
Stephen,
one point.
Sorry, go ahead.
I just want to add one point that is missing from a lot of these conversations is a lot of people kind of don't know what the next steps are, especially people who are kind of outside of the post-viral field. For me, all of my tests came back normal until I started seeing a myalgic encephalomyelitis doctor. Then none of my tests came back normal. And I think the biggest thing that long COVID providers can do is learn the right tests from people who have been in the field for decades. So natural killer cells, for example, the natural killer cell function decreases over time in long COVID patients. T cells are dysregulated. Ferritin is often low if it's not extremely high. Cytokines are abnormal. There's so many tests that can be done and treated, for things like dysautonomia. It's not perfect, but you can do things like mitodrine or beta blockers, as well as compression and electrolyte tablets. I think that one of the gaps that for me has been really missing is learning from those experts. And post-viral research and myalgic encephalomyelitis research is a tiny, tiny field. I think there are like 17 providers in the whole country. The wait lists right now are over a year long. But those are the experts, and they have put out an amazing PDF on kind of tests you can do and treatments that are available. There are no real cures available. There are no real kind of life-changing treatments available. And for that, we need more research and, recognition. But it's something that we really need kind of that information distributed much, much more broadly. And that's kind of one of the, things we're focused on as patient advocates is kind of showing that there are all these areas like brainstem dysregulation, abnormalities in the blood. There's so much good research out there that just needs to be highlighted and sent around to long COVID clinics.
Hannah, are you, can I just ask, or anybody, Shamir, anybody familiar with ways that people, I won't even call them patients, like humans, they can be family members, just interested friends, can help kind of navigate the system? Because frankly, like I'm a pretty smart doctor and I know a lot of people, but it is so hard. I mean, I would not order those tests. I wouldn't feel comfortable, and I'm board certified and everything, but I wouldn't even know how to figure out. I mean, sure, I can call Wes, I can call a friend at Sinai, I can call someone at Yale. They can't help my person kind of there. Is anybody in any of these groups, or maybe like the NHLBI or somebody, is somebody creating a way to kind of say, here are kind of, 5 questions you can ask to figure out if your care providers kind of have some of this knowledge, or here's how you can find that. And then I'm going to ask, it's hard to get access into these appointments. It's hard to navigate. And if my typical patient has, a job that doesn't pay well and drives for Lyft to and from so they can make money, and has kids that, he or she needs to take care of. So how do we do this when people don't have the time to navigate it? Is anybody developing I'm incredibly practical, so that is a fault of mine, but is anybody developing those kinds of resources?
Well, I do want to actually just ask Dr. Gibbons quickly kind of what your thoughts on this are. I mean, we know that research is the next stage in this, and I'd love to have you actually respond to Kavita specifically. How are we trying to bridge this gap, and what advice do we have for people who are actually navigating these systems?
Okay, well, it's a great point. It's one of the challenges of a really fast-moving, dynamic pandemic. We're trying to understand a novel disease. And so one of the elements that I think Hannah brought out is trying to convene together people who have various both lived experience of patients about what's going on, but also as Kavita was, as Hannah was indicating, there are other post-viral syndromes that could be informative in terms of their length of study. Certainly ME/CFS is one of those examples. Wes alluded to some of his work on, post-ICU syndrome. There's things about post-Lyme, et cetera. There may be some common themes about some of these responses to these microbial or other injuries that we can all learn from. And it doesn't mean that they're all going to be perfectly overlapping and the same, but I think by bringing together and really actually as part of the research, comparing and contrasting what we're finding and sharing that across these various experts, particularly in a multidisciplinary way, I think that's part of it. So that's one of the things we're trying to do in Recover is create those sort of cross-disciplinary teams that are not only just inclusive of scientists, but as we've tried to indicate, with patients as partners in this. So that's one. Some of you may have already seen recent output from the NICE, National Institute for Health and Care Excellence, in which there are groups that are convening, as well as the WHO. Internationally, they're trying to hone down on things that can help us speak the same language, what we call case definitions of what we're talking about with these syndromes, such that we can actually talk to each other and compare information across studies. That'll be important for us to convene those groups to be sure that we're sharing information across borders, across disciplines. And I think that'll be an important element. Certainly, as that evolves, one of the things they were able to do is to systematically go through what's out there. What do we know from Hannah's study, as well as something that might come from the CDC? Let's systematically put that together as a collective to figure out what do we know well, where are the gaps in what we need to know, and how do we fill them? So it was pointed out the various tests. But let's really see, can we scale that? And how applicable are those tests to the broad spectrum of patients with long COVID? I think when we put that together, we'll be able to give coherent information both to patients and, as Wes was saying, to providers as well, to give.
And Dr. Gibbons, when do you think we're going to see tangible findings from this research that can actually inform policy decisions and help folks that feel like they're struggling alone? Because I know there's a lot of excitement that this research is happening, but I think patients are also feeling resentful that there haven't been immediate answers. Do you have a timeline in mind of when we might actually see some of these conclusions?
Well, science moves at the pace of science. I know that's not going to be a satisfying answer, but in order to do investigation, and you've seen it in real time in this pandemic, you can't rush the result of a vaccine. As much as promising as it is, it takes time to do the systematic studies and put it all together. But we're moving as fast as we can. And we're also, to Shamir's point, we have to move at the speed of trust. And I think that was also Wes's comment, that we're doing this collaboratively with you. And so I think the things that will be critical, for example, is to help us to have inclusive participation, whether it's from your communities, as I think Wes was alluding to. This could be a great collaboration where we can bring together patients with ME/CFS, patients who have long COVID, to do the kind of comparative studies that we're talking about. That's will help us move more quickly. One of the things that I think Hannah acknowledged in her work is that much of the study was white and not really very inclusive of Black and Brown communities. We need to be sure that we're inclusive of those who've been most devastated by acute COVID, and really be sure that they are included in our studies of long COVID. That's going to take work, and that's going to take time and outreach and building of trust that Shamir alluded to. So those are the things that as fast as we want to go to understand this and relieve suffering, it's also important that we move at the speed of trust and do it in a way that's deliberate in being sure we're getting good science done as well.
Shamir, I want to ask you, Shamir, what are you feeling as you hear this? I mean, do you feel like you can wait for science to move at the pace of science, as Dr. Gibbons said?
I mean, it can be a little frustrating because I feel like I've almost been waiting for 2 years. But I will say this: I do understand. I'm learning every day about science moving at the pace of science. But what I like to caution organizations, health organizations, and any other organizations who say that they're patient-centered is that there needs to be a complete overhaul about what that looks like, because there are so many different navigations and so many different layers to what it means to be truly patient-centered. And I think sometimes we have to delve into so many different topics about that. For instance, being a part of these patient engagement practices in these studies also means being cognizant of patient energy and patient capability, because, for instance, I can't be on a meeting for 3 and 4 hours, trying to solve a problem. I need breaks. I need to be able to move. I have to be able to lie down. There's so many different aspects of this that we've got to start to sharpen and fine tune if we really are going to be patient-centered. And we have to listen to patient voices. What I believe, like I said before, there is no upset unless you really start. I think the major upset that has to happen is we have to completely start to think about the patient voice being a central voice. Now, that does not negate from a doctor's voice, but I think that in order to be successful with any type of patient engagement, we've got to stop the fighting, the infighting of, well, patients are, because the truth is, Fiona, we've been right. We were right before, we were calling it long COVID before a lot of other people were. We were galvanizing on social media. That's the reason why we're having this conversation. If we had not spent hours, Hannah, if we had not spent hours and hours and hours and hours on Twitter, on Instagram, on Facebook, there would be no conversations. Mm-hmm. So my thought is, just like I empowered my students before I had to stop teaching, their voices mattered. So if you're not willing to look at the patient voice seriously, then everybody's doing a disservice. And that's just the way I feel. Science or no science, we are doing a disservice if we are not putting the needs of the patients at the forefront and the voices, not just people who are implementing things and then coming back to the patients and saying, well, what you think about this? No, we need to be at the table.
You need a seat at the table. You need to be drivers in the research. And Stephen, I know you understand the urgency of this crisis because you have declared long COVID our next public health catastrophe. I mean, obviously, I agree with you. Shamir was saying we have been shouting this from the rooftops since we got sick, right? What triggered that level of alarm for you? Can you tell us a little bit more?
Well, not only the alarm, but now hopefully the solution. So just listening to, frankly, the disappointment and anger from Shamir and Hannah in terms of how long COVID patients are being treated, I think we have to look for solutions. The catastrophe is the sheer numbers and the sheer level of functional impairment and debility that's unrecognized, undiagnosed, untreated. So that the numbers that we highlighted in our New England Journal piece conservatively say that 15 million Americans are or will be affected by long COVID. They present with a range of up to 200 symptoms affecting any and every organ system in the body. And as we've heard very eloquently from a number of physicians, the healthcare system is not organized structurally, professionally, or culturally to handle this massive pandemic within a pandemic. So what are the solutions? And I heard Gary actually hit the nail on the head, which is essentially, how do we get on the same page? How do we listen to each other and hear each other? And I think that's the answer. And if I could just challenge everyone on this panel and many in the audience, the light bulb went off for me in comparing a lot of what I'm hearing to the AIDS activism of the 1980s and 1990s. And I wish for us to go back to the HIV/AIDS playbook, because I think ultimately what happened there, and it took way, way too long. I'm not advocating a 10 or 20 year dogfight here. Ultimately, what happened is the AIDS activists turned frustration, anger, and outright hostility toward the formal medical structure and the biomedical model, and they turned that on its ear to be listened to be respected, to have research that actually came to fruition in terms of curative medications. I think the same playbook here would be well advised, and I think we're very, very much in the early stages of frustration and anger. And the playbook says, why don't we try to understand what the biomedical system standards, criteria, mindset is, and let's see if they can understand more where we're coming from. And it was not an easy process, but ultimately, I think the activists learned to operate and actually turn the levers of the biomedical enterprise to their benefit, both on the research side and, by the way, also very much on the clinical treatment side. If you remember some of the early hostility of against AIDS patients, I mean, it's kind of like what I'm hearing now. So what I would plead for from all of us is to understand what Gary was saying in terms of case definitions. What is a case of long COVID? Granted, there's not a clear handle, but why don't we listen to patients? And why don't patients listen to some of the doctors who are well-informed and empathetic? And let's figure out how to define it. Let's figure out what the outcome variables are in a standard way, just so we can study it. Right now, what we're hearing is a lot of noise, but not a whole lot of signal. How do we turn that noise into signal?
Just want to.
And I think I'm glad that you're bringing up HIV/AIDS, because I know that both Body Politic and the Patient-Led Research Collaborative have looked a lot at ACT UP's work and really tried to incorporate that. And so, Kavita, I want to ask you, because for me, this feels like a pivotal moment in history, an opportunity to learn from those mistakes of the past, to redefine patient engagement, as Shamir was saying, and as Hannah is doing, and to tap into disability justice movements, and really just do right by everyone who has been made disabled and chronically ill by this disease. But as Stephen points out, this is not the first disease outbreak that has led to long-term illness. I mean, we had HIV/AIDS activists who similarly had to fight to be heard. And we also have people with myalgic encephalomyelitis, as Hannah mentioned, who are similarly, they're still fighting for that recognition. So Kavita, I want to ask you, how do we make sure that our approach to this disease stands on the right side of history?
Yeah, I think we have to start by not isolating it to kind of the traditional medical complex. Like I think that we need, it's traditionally called kind of a health and all policies approach, but this affects every aspect of your life. I only see someone for 15 minutes, maybe, once a month if I'm lucky, and their 99.9% of their lives are lived in schools, around people, in jobs, can't keep jobs. Disability is very interesting that you mentioned, like the complex process of filing for disability or even long-term leave is so burdensome, and that's left to who? It's just left to the individual. So I would love to see, as part of like what I think is happening, where we're talking about infrastructure and economic recovery, like I want to see this kind of baked into that in a meaningful way, so that we're like really looking at like a longitudinal process of care. Because I got news for you. Most of our doctors, like, I'm putting on a nice face, I put on makeup, I look really happy. We're all tired. And I don't know if we can ask doctors to kind of, I mean, I agree with Wes's like moral kind of how injurious my actions have been, but I don't know that I can take more and ask more right now. So we have to kind of all do our part. And I'll just end with like, and that means supporting the family. So we need to expand the N of one and take it, and family is loosely defined. So this is what we saw in HIV/AIDS, that we needed to look at society. And I can't help but think that, you know, until we had like celebrities and like really popular people on social media, like a Kardashian, people didn't actually notice long COVID as much. And I'm willing to even ride that wave if it'll get people to talk about it, but talk about it not just in clinics and hospitals, but to talk about it in classrooms and to teach about it, just like we do all sorts of injustices.
Absolutely. We only have a minute left, so I just want to go very quickly to each person here, get your reaction on that. Dr. Eli.
Yes, I'll tell you three things. One is that in addition to the HIV/AIDS playbook, we have to recognize too, there's one big difference here in the societal implications of COVID is that people who never got the virus have also been injured. We haven't mentioned them once, and that's silencing them as well, because there's a lot of PTSD and depression in people who never got the virus because it happened to the whole society. So let's not forget those people. Secondly, we have tons of support groups here in the SIB Center, for example. We have people from all over the country, spouse support groups, COVID support groups, ICU survivor support groups. These support groups need to be expanded on a much larger scale. Shamir mentioned that. That's a second big time solution that has got to happen. We have all these Zoom groups here within the SIB Center, but it's going to have to grow out much bigger than that nationally. And thirdly, what Kavita said is right on. People cannot navigate disability, and they're losing their electricity, they're losing their lights, they can't get on their internet anymore, so they can't apply for disability or insurance. So for example, with every penny that I get from this book, we're hiring in the SIB Center. It shouldn't rest on just a private organization, but I mean, we're a public research organization, but still, we're hiring social workers and insurance specialists to help COVID survivors figure out how to get their insurance and disability done. So we're going to do that for our patients, but what about on a national scale, employing these social workers and insurance people to help all these people navigate this, because it is a nightmare and they just can't do it.
Absolutely. Thank you so much for pointing that out, that holistic approach. Dr. Gibbons, final thoughts from you?
You know, I love your focus on the holistic, taking that holistic approach both to the patient engagement, that collaborative shared decision making and co-creation with researchers and clinicians. And really, I thought Stephen's point was well. We're all on the same team here. We recognize that this is a devastating impact, and it's really going to take all of us collectively working together, sharing our knowledge, and it's an and broad omnidirectional exchange with, again, the lived experience experts of patients as well investigators and providers to figure this out. And it's going to take teams to collaborate on this and eventually systems, as Dr. Patel was indicating, that are going to have to rearrange and accommodate themselves. And I think we're going to have some innovative approaches. I'll just point out one other thing that resonates is that another parallel to AIDS is some of the rare disease communities that had the same sort of challenges of caregivers not really understanding their disease, them having to form support groups. Some of those foundations actually are driving clinical trials now of their disease. So we've seen similar models work, and I think it can apply here as well. I'll stop there.
Hannah, I'd love to hear your final thoughts. What are your hopes for this NIH research? What would you say to someone dealing with COVID right now?
I mean, I think we all really feel, I mean, our biggest hope would be recover, and we were really excited about it. But I think right now, as someone who participated, they're kind of failing the patient engagement. We definitely are not being acted as partners. We need a structure that holds the researchers accountable to patients. There's some kind of board or something, you know, patients at every site. There's a lot that needs to be done there specifically. To someone who has long COVID, I would again say, you know, there's so much information out there. It is, you know, it is possible to get some treatment. Look to myalgic encephalomyelitis doctors. There's new interesting research on microclots in Germany and South Africa that are pretty promising as well. And of course, joint body health, which is a lifesaver for many of us.
Okay, and if I may just, Hannah, we can do this offline. But if there are things that recover is falling short, please don't hesitate to contact us. We're trying very hard to engage patients at every level, steering committee, executive committee, of decision making. So it's in addition to co-creating the protocol and the design. So we're committed to this. And if we're not getting there, and it's at the level of the consortium as well as the local level, if it's not working, give us that feedback. Let's see how we can fix it together.
Thank you. I'll reach out to you.
I'm glad to see that conversation is starting, and clearly we've made some progress just here today. So thank you all so much. Unfortunately, we've reached the end of our time. I think we could go on talking about this for many more hours, but hopefully we'll continue to. I'd like to thank Dean Williams of the Harvard School of Public Health for highlighting this incredibly important topic and keeping it in the forefront of our minds. Long COVID is not going away anytime soon, and I am so grateful to all of you who tuned in today and engaged. Now, if anyone watching today is dealing with long COVID, please see the resources on your screen. These are some support and advocacy groups. Body Politic is the private support group I founded that is housed on the Slack app. Patient-Led Research is the collaborative Hannah Davis co-founded. And ME Action is an advocacy organization with support groups for people with ME/CFS, which we've been discussing, which many long COVID patients have been diagnosed with. This is only a partial list of resources. There are so many amazing groups and individuals doing this necessary advocacy and support work for long COVID. A longer list will be available on the website later today for those of you who are interested. Thank you all again for tuning in, and have a good day.